Hey.
Thanks for having me.
I think Romualdo. Hi, Romualdo.
Hey, sorry, I had some problems here. Hey, Sara. Hey, Debora. Hey, Jorge.
Hi, how are you?
Hey, Romualdo, how are you?
Fine. Fine, thanks. Let me put my
Perfect. We are.
my Hogwarts library here.
Oh yeah, you should. I work at the best library ever.
I can show you, Romualdo, I don't have that, but I can show you a sea view, but I don't want to, envy you guys.
Yes. Please show us. Show
Okay,
Sarah,
I can do that.
What view do you have?
I don't think well, let me see if you can have it better here. We're right close to the beach here, Sarah. So just in case you don't know Salvador, Bahia, can you guys see anything? Let me see here.
A little hard with the blind.
Yeah, I'm sorry. Yeah, technology,
Well,
it's not
I can guarantee that the waters in Salvador are much warmer than in Boston.
Yeah.
Probably true.
Okay. So, Sara, it's a pleasure to have you here today with the Brazilian Breast Cancer Study Group. I will ask Romualdo to introduce you and then to start our discussion.
That's great. So that's my pleasure, my joy to have Sara here. Sara is Dr. Sara Tolaney is senior physician at Dana-Farber.
Pleasure to have you here today with the Brazilian Breast Cancer Study Group.
Well, we are having some problems. Sorry. So, and Dr. Tolaney is also an assistant professor at Harvard Medical School. And I have the great pleasure to call her my mentor and my dear friend. And so Sara will talk today about immunotherapy in early breast cancer with focus in triple negative breast cancer. So Sara, please be welcome. Thank you.
Thanks so much for having me. Are you guys able to see my screen?
Yes.
Yep.
Okay, great. So today I'm going to focus on neoadjuvant immunotherapy approaches in breast cancer. And while I realize this is still early on in development, I think we've seen a lot of very exciting data that has emerged in this space. So we certainly realize that breast cancer received its first approval for immunotherapy back in March of 2019. And this, as you all know, was based on data from Impassion 130, in which patients with metastatic triple negative breast cancer were randomized to receive chemotherapy with nab-paclitaxel with or without atezolizumab as their first therapy for metastatic disease. Patients were stratified by PD-L1 status, and the study was designed to have co-primary endpoints of both progression-free and overall survival within the intent to treat and within the PD-L1 positive population. So in essence, the study had 4 co-primary endpoints. And the study did demonstrate that there was an improvement in progression-free survival in the intent to treat population, but this was really driven by the PD-L1 positive subgroup. And we saw that the overall survival benefit was really only seen in the PD-L1 positive subgroup, with no benefit seen in those patients with PD-L1 negative disease, really leading to the first FDA approval for immunotherapy for breast cancer due to this clinically meaningful 7-month improvement in survival, although important to note it was not statistically significant given the hierarchical design of the trial. So while it has become standard to utilize checkpoint inhibition in those patients with PD-L1 positive metastatic triple negative breast cancer, I think many of us have been a little disappointed, particularly by the small PFS benefit seen from the addition of atezolizumab to chemotherapy. And many of us have wondered if the benefit from checkpoint inhibition may in fact be greater in an earlier disease setting rather than in the metastatic setting. So in looking at studies that have compared primary and metastatic tumors, we can see that primary tumors are associated with higher levels of tumor-infiltrating lymphocytes and higher PD-L1 expression when compared to their matched metastatic samples. And we also know that PD-L1 expression tends to be higher in primary breast tissue relative to metastatic sites such as liver and soft tissue metastases, where we saw these data presented from Impassion 130, again with higher PD-L1 expression in the primary relative to the MET and higher expression within breast, lymph nodes, and lung relative to, for example, liver. We also know that high tumor-infiltrating lymphocytes are predictive of response to checkpoint inhibition. We saw this both from Keynote 119 as well as from Keynote 86, two trials that were really looking at checkpoint monotherapy, where we saw that higher TILs were associated with greater response. Additionally, there is some data to suggest that higher PD-L1 expression may be associated with greater response to checkpoint inhibition, and we saw this in Keynote 119, where chemotherapy was compared to pembrolizumab monotherapy in patients that had received 1 to 2 prior lines of chemotherapy. And while the study overall was negative and with really no difference seen in survival between chemotherapy and pembrolizumab, you can start to see incremental benefit for pembrolizumab as PD-L1 expression increases, to the point that finally, when you get to CPS greater than 20, you can actually see the curve start to separate, suggesting that pembrolizumab performs better than chemotherapy in those patients with very high PD-L1 expression. We also have some data looking at immune profiling of paired primary and metastatic triple negative samples, where heat maps of composite expression scores of immunomodulatory gene signatures between primary and metastatic specimens showed composite scores from 3 to 4 different gene signatures that were significantly downregulated in metastatic samples compared with primary samples. And you can see that the box plots illustrate decreases in these gene signature scores between the primary and the MET. And we also saw that there were changes in cell subtypes between the primaries and the metastatic samples, again suggesting a more immune poor microenvironment in the metastatic samples relative to the primary samples. So understanding that primary breast tumors may be more immune rich, the I-SPY2 study explored adding pembrolizumab to standard anthracycline and taxane chemotherapy, and demonstrated that the addition of checkpoint inhibition significantly improved rates of pathologic complete response in patients actually with both triple negative and hormone receptor positive disease, with PCR rates that were almost 3 times better from the addition of pembrolizumab. So given these promising data, we've now seen data emerge from a large phase 3 study, Keynote 522. This trial randomized approximately 1,200 patients with triple negative disease to receive chemotherapy with carboplatin with paclitaxel, followed by anthracycline and cyclophosphamide, with or without pembrolizumab prior to surgery. And then after surgery, all patients in the pembrolizumab arm went on to receive 9 cycles of pembro, and this was compared to placebo. And this study was designed to have co-primary endpoints of both PCR and event-free survival. The study demonstrated that adding pembrolizumab to chemotherapy increased rates of PCR from 51 to 65%. So really an absolute improvement of almost 14% between the 2 arms. And very interestingly, this benefit was seen regardless of PD-L1 status. So approximately 84% of this population was PD-L1 positive, as defined by having CPS score with the 22C3 antibody greater than 1. And you can see again benefit within both the PD-L1 positive group, with about a 14% difference in the PD-L1 positive subgroup, and interestingly, an even larger difference in the PD-L1 negative subgroup with a delta of about 18%. When specifically looking at outcomes by degree of PD-L1 expression, we can see again the benefit seen in all patients regardless of the degree of positivity. But it's very interesting to note that in general, PCR rates are higher regardless of treatment arm. So again, as the CPS score goes up, in general, in both arms, you can see that PCR rates increase, and the delta, again, continues to be around 14 to 18%, again, regardless of PD-L1 expression. So we only have data from an interim analysis for event-free survival. And so with just 18 months of follow-up, we can see that there is separation of the curves with fewer events occurring in the pembrolizumab arm relative to the placebo arm, with a hazard ratio at this time point of 0.63. This did not meet statistical significance. By the way, the interim analysis was pre-planned. You had to have a hazard ratio less than 0.4. So patients remain in study follow-up, and we are hoping to see an updated interim potentially later this year. Interestingly, though, we also saw data looking at preoperative atezolizumab in patients with triple-negative disease in the NeoTrip study. This study was slightly different in that it did not utilize preoperative anthracycline. So the study took patients who had triple-negative tumors and randomized them to receive 8 cycles of carboplatin with nab-paclitaxel with or without atezolizumab, and then patients went on to surgery, and then out back received 4 cycles of anthracycline and cyclophosphamide chemotherapy, and then were placed into follow-up. Interestingly, the primary endpoint for the study was actually event-free survival, which we do not yet have, but we do have the secondary endpoint, which is pathologic complete response. And in contrast to data that we saw from KEYNOTE-522, there was actually no difference in PCR rates between the 2 arms. And this was true regardless of PD-L1 status, where you can see, again, no difference in the PD-L1 positive group and no difference in the PD-L1 negative group. We see the same trend that PCR rates in general, regardless of arm, are higher in PD-L1 positive patients compared to PD-L1 negative patients. But again, no difference seen from adding atezolizumab to chemotherapy in this trial. So, well, you know, the data that we have available to date is still minimal. I think it leaves us with a lot of questions. As you can see here, I think the first question is, does choice of chemotherapy backbone matter? And could that potentially explain why we are seeing differences between KEYNOTE-522 and the NeoTrip study? So while we don't have data in the preoperative setting comparing various chemotherapy backbones with PCR rates in a prospective fashion, we do have data from the metastatic setting in the TONIC trial, in which patients were randomized to get an induction of either radiation, cyclophosphamide, cisplatin, or doxorubicin, or control, and then went on to get nivolumab therapy. And this study demonstrated that the majority of responses were seen in those patients who received anthracycline treatment as well as platinum therapy. And they also saw that there was upregulation of immune-related genes that are involved in PD-1, PD-L1, and T-cell cytotoxicity in these arms. And it's hard to know if this is really sufficient to explain the difference in outcomes between KEYNOTE-522 and the NeoTrip study, since NeoTrip did not give concurrent anthracycline with checkpoint, but did utilize a platinum backbone. And certainly platinum, while inferior to anthracycline, still does seem to have synergistic activity. So, you know, I think there may be some suggestion from this that potentially one explanation for the lack of positive data in NeoTrip may be lack of anthracycline concurrently with immunotherapy in the pre-op setting, but I think it's certainly hard to know. So could another potential explanation for the difference in outcomes be the difference in antibodies that were used? So Keynote 522 used a PD-1 inhibitor, whereas Neotrip utilized a PD-L1 inhibitor. And we do know that inhibition of PD-1 allows for inhibition of interaction with both PD-L1 and PD-L2, whereas PD-L1 inhibitors really only inhibit interaction with PD-1. It's certainly hard to know if this is enough to impact efficacy differences. And we do not have randomized data at this time comparing the various checkpoint inhibitors to one another. There is one trial that is currently enrolling that is randomizing patients with metastatic triple negative disease to receive chemotherapy either with nivolumab or pembrolizumab or atezolizumab. This is looking at a novel oral taxane, tacecitixel, in combination with these agents. And the study is not powered robustly enough to compare the checkpoint inhibitors, but may give us some very interesting initial biomarker work to see if there are differences between these three agents. There is data to suggest that toxicity is different between PD-1 and PD-L1 inhibition. In Keynote 522, we can see that there were higher rates of thyroid toxicity and adrenal insufficiency compared to Neotrip. And this has also been seen in a meta-analysis where we can see that those patients receiving PD-1 inhibition tend to have more immune-related toxicities compared to PD-L1 inhibition. So, while we don't have differences in efficacy, I think there is sufficient data to suggest toxicity is greater with PD-1 inhibitors. I think one additional question is whether or not sequence would matter. Does it matter if you give checkpoint concurrently with chemo, or should we be given checkpoint followed by chemo, or vice versa? And so one study that did suggest that potentially sequence may matter was the Debora Nuevo study, which randomized patients to get an upfront window of durva versus placebo in a subset of patients, and then went on to get concurrent treatment with taxane followed by anthracycline cyclophosphamide therapy prior to surgery. And while in the overall study there was no statistically difference in PCR, you can see there was certainly a trend towards improved PCR with durva compared to chemo alone. But interestingly, if you looked at outcomes for those patients who received the window of durva prior to getting chemo, actually those patients did do better with higher PCR rates. So I think this does suggest that potentially an upfront window of checkpoint inhibition may be an important thing. And they also saw that there was an increase in TILs in those patients who received the window treatment from baseline to post-window exposure. So potentially the windows allowing improved TIL infiltration prior to initiating chemotherapy, and this may allow for improved efficacy. But again, this was a small window study, and we would need larger data sets to know if this is true. So while Keynote 522 suggests very robust activity for pembrolizumab with taxane, platinum, anthracycline, cyclophosphamide backbone, I think many of us feel that this may be over treatment for many patients. And is it possible to potentially use the addition of checkpoint inhibition to de-escalate the chemotherapy backbone? So one small study that did explore this was from the I-SPY study, where they compared giving standard ACT to replacing AC with Pembro and adding Pembro to the taxane. And this study did not meet formal stopping rules to graduate this regimen to suggest it would be superior to ACT chemotherapy. But interestingly, the taxane with Pembro did seem to perform as well as ACT. I think the challenge here is that this control arm did not get pembrolizumab. And so we don't know that it would perform just as well as AC, Taxol, Pembro, which, you know, really is, I think, the ultimate question. We also saw some very interesting data that emerged at ACR just a few weeks ago, where another arm of the I-SPY trial compared adding durva plus olaparib, so PARP inhibition with checkpoint inhibition, to the taxane backbone and compared it to the ACT backbone here. And here you can see that regardless of subtype, there was an improvement in PCR with adding durva and olaparib. I think here the challenge is that they added 2 agents, and so we don't know if the benefit is really from the PARP synergistic activity with checkpoint and chemo, or if we would have just seen this with durva alone. And so again, I think the challenge here is the control arm. And, you know, I think it would have been more easy to understand if the control had also had durva, and the question was, what's the benefit of adding olaparib? So, you know, I think we need more data here, but there's certainly some interest in this, knowing that PARP inhibition can augment STING activation and potentially result in synergistic activity with PARP, and so with immunotherapy. And so could this be a potential mechanism to de-escalate chemotherapy if adding a targeted agent can augment the immune response? And while this is an interesting signal, much further work is needed. So we again learned in KEYNOTE-522 that adding checkpoint inhibition to chemotherapy results in improved PCR, but this trial did administer 9 cycles of adjuvant pembrolizumab. And I think that leaves us with the question is this really needed? And if so, what's the optimal duration of pembrolizumab? And furthermore, you know, we no longer treat patients with just standard adjuvant therapy post-preoperative treatment. In fact, we adapt our therapy in the post-preoperative setting based on achievement of PCR or not. And so one could ask, if someone achieved a PCR to chemo pembrolizumab, is giving more pembrolizumab actually needed? They've done so well, their outcomes are likely to be outstanding. Do you need more immunotherapy to improve long-term outcomes? And conversely, in someone who fails to achieve a PCR and has residual disease, one could argue, well, that patient didn't respond to pembro, it didn't help them. Why do we think giving more is actually going to add benefit? I think the other challenge is that it has now become standard practice for those patients who have residual disease to give adjuvant capecitabine. This is really based on data from CREATE-X that did teach us that using adjuvant capecitabine improves not only disease-free, but also overall survival within those subgroup of patients who had triple-negative tumors. So how would we then adapt our treatment if KEYNOTE-522 becomes a standard regimen? What would we do to those patients who have residual disease? Because in 522, again, all patients got pembrolizumab. So should we just give them pembro? Should we give them capecitabine? Should we give them capecitabine with pembro? And, you know, I think this is an unknown question, simply because, again, there was no adaptive approach that was utilized in 522. We will gain some data from the ongoing studies looking at checkpoint inhibition in the post-preoperative setting. So the SWOG trial was randomizing patients with residual disease to a year of pembro or observation. And these patients could have gotten adjuvant capecitabine prior to going on to the SWOG trial, so they could have received it sequentially, but were not allowed to receive cape concurrently with pembro. And the ABRAVE study is taking patients who either have residual disease or high-risk triple-negative disease after adjuvant therapy and randomizing them to a year of avelumab, so PD-L1 inhibitor, or observation. I think the challenge with interpreting these data will be that these patients did not receive preoperative immunotherapy. So it will not address the question that we will have if we're practicing in a post-522 environment, about whether or not adding pembrolizumab to someone with residual disease after pembrolizumab is going to have benefit. And so I think it will be challenging to know how to utilize these data once 522 is approved. So while 522 shows benefit in terms of PCR and perhaps will show benefit in terms of event-free survival, if that becomes the case, will we need to give all of our patients with triple-negative disease pembrolizumab in addition to chemotherapy? So we know that the added benefit of pembrolizumab was greater for those patients who had higher anatomic disease, with lower benefits seen in those patients with less anatomic risk. So if you look at those patients with stage 2A and stage 2B disease, you can see the difference in PCR ranges from about 8 to 11%, whereas when you get into the stage 3 patients, the difference is around 25%. So clearly much greater benefit in higher stage patients. And similarly, we can see really very small benefits for node negative patients, but much larger benefits for node positive patients. And I think we have to weigh these benefits with the potential lifelong toxicities that can result from giving immunotherapy to a patient who is in a curative treatment landscape. These women could live with adrenal insufficiency, thyroid toxicity lifelong. And is that worth it for a 5% difference in PCR compared to a higher risk patient where clearly the risk benefit ratio is dramatically different? So while there seems to be great promise for immunotherapy for patients with triple negative disease, I think many of us wonder if we will see benefit for immunotherapy in patients with ER positive disease. We know that ER positive tumors have lower tumor infiltrating lymphocytes compared to triple negative and HER2 positive tumors. We also know that ER positive cancers have lower PD-L1 expression and lower tumor mutation burden, making us think that these cancers are less likely to be sensitive to immunotherapy. And certainly that data has borne out with some initial clinical experiences where we saw that response rates to pembrolizumab monotherapy for metastatic PD-L1 positive ER positive disease was only 12%, and then even lower for unselected ER positive patients with avelumab with only a 3% objective response rate. So very disappointing activity for checkpoint alone in metastatic ER positive disease. Then our group had done a study comparing chemotherapy with eribulin with or without pembrolizumab in metastatic ER positive disease and demonstrated no benefit to adding pembro in this setting. And certainly it's unclear if lack of benefit was due to the chemotherapy backbone here or lack of selection for patients by PD-L1 status, or the fact that these patients were fairly heavily pretreated, as most patients had progressed on prior CDK4/6 endocrine therapy, and most had had one prior line of chemotherapy for their metastatic disease. So there's some thought that maybe we would be more successful with immunotherapy in ER positive disease in an untreated population. So if we moved immunotherapy to the preoperative setting, where would we have more tumor infiltrating lymphocytes in a more immune-rich environment relative to the metastatic setting where we may potentially see more success? So there's a checkmate study as well as a keynote trial exploring adding either nivo or pembro to preoperative chemotherapy in high-risk ER-positive patients, and both of these trials are currently enrolling. So we will have to wait data to see if there will be any benefit for immunotherapy in the early disease hormone receptor positive patients. There's also some data to suggest that CDK4/6 inhibition may augment immune response, with data suggesting increased antigen expression and synergistic activity in preclinical models with checkpoint inhibition. And so there is an ongoing study looking to add immunotherapy to endocrine therapy and CDK4/6 inhibition in the preoperative setting for patients with ER-positive tumors that is currently enrolling, looking at differences in RCB at time of surgery. So I think in summary, what we've learned is that neoadjuvant checkpoint inhibition with chemotherapy is not yet a standard of care for triple-negative breast cancer. While we've seen an improvement in PCR from KEYNOTE-522, the event-free survival data is still immature and has not reached statistical significance. So we'll have to wait to see with longer follow-up if event-free survival is improved from the addition of pembrolizumab to chemotherapy. And while there was no difference in PCR by PD-L1 status, I think we wonder if we may see differences in event-free survival by PD-L1 status. And so I think we will have to await that data as well. And so if 522 is positive, would adding pembrolizumab be a standard for all triple-negative patients, or should we restrict its utilization to certain patients with higher anatomic risk? We don't currently have a biomarker to help us select those patients at this time, but we do know that higher anatomic risk was associated with greater benefit, and given the potential for lifelong toxicities such as adrenal insufficiency, diabetes, and thyroid toxicity, I think potentially restricting utilization of pembrolizumab to those higher risk stage 2, 3 patients probably is warranted. And so if, again, 522 becomes a standard, I think there's some concern from many of us that we are potentially over-treating many patients with very aggressive chemotherapy backbone with platinum, taxane, anthracycline, and cyclophosphamide. And I do think we will need to do work to see if we can de-escalate that chemotherapy backbone to try and mitigate toxicity. Additionally, I think there's a lot of unknowns about what the benefit is of postoperative checkpoint inhibition and what the appropriate regimen should be for those patients with residual disease, and whether or not combination therapy with chemotherapy and checkpoint inhibition may be beneficial in those patients, again, with residual disease. So thank you so much. I appreciate it.
Thank you, Sara. Great lecture, very clear, very didactic. I would like to present our colleagues, Dr. Debora Gagliato from São Paulo and Dr. Jorge Leal from Salvador, Bahia. They will discuss and they will ask you questions. So please, sure. Debora and Jorge, feel free to start.
Thank you, Sara, for your fantastic presentation. I think it was a brilliant a summary of everything we have now on data on immunotherapy in the early setting for breast cancer. And I think we are very excited for our patients, especially for triple-negative breast cancer, in which we know that PCR is a very important endpoint. So do you think pembrolizumab or other immune checkpoint inhibitor will be approved in the next months in the neoadjuvant treatment of neoadjuvant therapy? And would you started the discussion, but do you think like an early breast cancer, like a 2 centimeters node-negative triple negative breast cancer who received the KEYNOTE-522 regimen and has a PCR, how would you offer him her adjuvant immunotherapy? How would you tailor, and would you tailor the treatment according to the response to the neoadjuvant therapy?
Yeah, no, good questions. You know, certainly, I'm not certain about the timing of when we may see an approval for 522. I think it's potentially possible we could get updated event-free survival data later in the year, potentially at ESMO or San Antonio. And if that were the case, and if we saw there was significant improvement in event-free survival, I would think that that would lead to, at least in the United States, for the FDA to approve adding pembrolizumab to chemotherapy in the early disease setting. And so if that does become the case, you know, again, I'd like to see the event-free survival data also by PD-L1 status. You know, we know that it didn't matter for PCR, but I also would want to make sure that that's true for event-free survival. And so then if that is the case, and then we turn to your patient that you posed, if someone had a, smaller cancer, like a 2-centimeter cancer, who had residual disease, or who had a PCR?
Who has, in both cases, who has a PCR and residual disease. Would you tailor the treatment according to the response to the neoadjuvant therapy?
And they got neoadjuvant immunotherapy with chemotherapy?
Like the Keynote 522 regimen.
So, I mean, I think it's a great question, and certainly I don't really have an answer except to say that, if someone had a PCR, I think, and did okay with pembrolizumab, meaning that they, don't have contraindication to continuing checkpoint inhibitor therapy due to some toxicity they may have developed in the preoperative setting, then I probably would continue and give them their 9 cycles of pembro. I think the challenge is we don't really know what duration of immunotherapy you need to give to see the event-free survival benefit. And so if they weren't having toxicity concerns, I probably would give them the 9 additional cycles. If they didn't have a PCR though, and they had residual disease, I would hesitate to omit capecitabine, because we do know that the capecitabine improves disease-free and overall survival. And so I might do something that's totally not data-driven, but might give them capecitabine with pembro, so that I continued the pembro as was done in 522, but added on capecitabine. We do have some safety data from it. There was a study presented, as you may all know, from ASCO last year, where the combination of CAPE and pembro was explored in metastatic triple-negative disease as first-line therapy, and had very nice activity and safety. So I think, at least there's safety data, but again, I have no data to know if doing the pembro with the CAPE is needed or not, but I think I would probably do that because we just don't have another, set of data to work from.
Yes, I totally agree.
Sara, I have a quick question for you. And first of all, thanks for your time. It's a great opportunity for all of us to be able to listen to such a great talk. And so I had a few opportunities to work with immunotherapy while I was in LA with Heather, your colleague. And so we always thought about how to better prime breast cancer before giving the chemo plus the IO, as we saw the induction phase at the Durva with the Gepard Nuevo. So do you think it would be interesting if we know for sure patients will have to have adjuvant radiation therapy to their breast, try to move up front, like the boosting therapy for the radiation, priming with an IO, keep going with like a less toxic, for example, chemotherapy backbone, trying to reach the same PCR and maybe the same EFS that we might see with further follow-up with Keynote 522? Because when we look at the toxicity, it's completely different when you look at the chemo IO phase, and then when you go only to the IO phase after chemotherapy. So maybe most of the toxicity has been driven by the combination chemotherapy backbone IO than only just the IO itself. I just want to hear what are your thoughts regarding this.
Yeah, it's actually a really interesting question. Certainly Romualdo has also done a lot of work on combining radiation with checkpoint inhibition based on very robust preclinical data for that. And I know Alice Ho, actually with Heather they have a couple trials where they're actually exploring this right now, where they give the boost concurrently with the checkpoint prior to chemotherapy with continuation of the immunotherapy. And I think the challenge is there's just so many unknowns in that setting. There's very limited data with safety and impact on, how do you assess PCR in someone who just got the tumor radiated? It's going to be a complicated question to address. And so, I think it'll be interesting, and there's certainly very good data for it. And you're right that maybe it would be a way to get rid of some of the chemo if we could just get such nice synergy from the radiation. And so I think it's a very promising approach, and it's, there's ongoing studies looking at it. So we'll have to see what it shows. I'm just challenged by how we'll interpret the early data because of the upfront radiation without good historical control to correlate with long-term outcomes. And so it may take some time, with event-free survival data to really flesh that out.
I have another question regarding the I-SPY2 trials. We saw that patients with hormone receptor positive breast cancer immunotherapy also graduated, improving PCR in addition to chemotherapy. Is there a patient who has hormone receptor positive? Do you think we have to have a genetic test like mama print ultra high to recommend this type of strategy to these patients?
I mean, it's a great question because, you know, I think certainly our group has been very interested in trying to look at immunotherapy, and at least in metastatic ER positive disease, and we haven't had any success to date. And so, you know, even if you move it earlier, as was done in I-SPY, as you know, all those patients did have high mammoprint. And so is the reason we're seeing benefit in I-SPY because they're all mammoprint high? Is there something different about those tumors relative to mammoprint low tumors that would suggest there'd be better, you know, a more rich, for example, immune microenvironment to lead to synergy? And so I think it's a great question. Certainly we know chemo works better in those patients, so you would think you get more antigen release, potential more synergy with IO. And so maybe you just need a tumor where chemo works to get the immunotherapy to also work. So I think it's a very good point. And, you know, I think with developing the registration trials, looking at either Pembro or Nivo, there was a lot of debate about whether or not they needed to restrict to high oncotype or not for eligibility. And, you know, I think that came with some challenges, you know, and I think there's also interest in restricting to high anatomic risk as well. And my guess is we may see benefit in some, you know, high genomic risk and high anatomic risk tumors. But I think there's just so many unknowns with ER positive disease, but I think it's a good point.
Thank you. I think we have more questions. I would like to ask Dr. Diniz to unmute and make your question to Sara, please.
Thanks for the great presentation. And from a mechanistic standpoint, maybe you could help to explain why the larger benefit of the checkpoint inhibition in the higher stage tumors as opposed to the earlier stage.
Yeah, I mean, I think in general, we know that we tend to get more absolute benefit in higher risk disease, you know, because of the relative reduction becomes more as the risk goes up. But I do wonder if having more tumor in place while you're giving immunotherapy may lead to more antigen release and more, you know, synergy with the cancer being in place. And I do also think that maybe that's why we tend to see more benefit in the pre-op setting as opposed to the adjuvant setting, because again, the tumor is in place. So having more tumor there allows for more identification of the cancer by the immune system, as opposed to, for example, the adjuvant setting where that's not there. So perhaps having more of it there also allows for more synergistic activity. But it's a good question.
Thanks.
Sara, do you think that PARP inhibitors on top of chemotherapy and immune checkpoint inhibitors are going to be, is there any role for PARP inhibitors? We saw like data on AACR, but like you mentioned in your lecture, both treatments were given to the patient with chemotherapy. We don't have like an arm only with PARP inhibitors and then chemotherapy PARP plus immune checkpoint inhibitors and chemotherapy.
Yeah, so I think it's hard to know from I-SPY because of that there wasn't, you know, a 3-arm randomization to help tease out the, you know, contribution of effect from each agent. We do have data from the metastatic setting, you know, looking at combination therapy, both from the Mediola study with olaparib and IO, and then the Tapatio study looking at niraparib with Pembro. And I think those data are also very hard to interpret because they were single-arm trials. And if you look at the BRCA mutant populations, the response rate is similar to what we would have expected from PARP alone, given data from Olympiad and Embraca. And then if you look at PFS, again, comparing it to historical control, maybe it's a little bit longer, but not by much. And so I think we really need randomized data to help figure that out. And you know, there are a couple now ongoing randomized trials looking at PARP with or without immunotherapy, one as monotherapy and one as in a maintenance setting, and the metastatic setting. And so I think we'll gain more data to really know if there is enough synergistic activity between those two agents. But I think your question's a good one because it's not just PARP-IO, it's also PARP-IO chemo. And, you know, I think, again, from I-SPY, it's just too difficult to tease out if that's really adding.
Perfect. I think we have more questions from Carlos Barrios. Barrios, could you unmute your microphone, please?
Hi, Sara. Thank you very much. Nice question. A couple of questions. This data were in PCR in the first 600 patients, and the trial included almost 1,200 patients. Are we ever going to see the data on PCR on the whole patients that were recruited?
My assumption was that that would come soon, but I'm not sure of the timing.
Because the statistical design said that this trial, as far as PCR, is over. So I was wondering whether all that information on PCR on 1,200 patients.
It should be available. Yeah.
The question was to address the issue that I heard from the company that that's not going to be the case, and they're going to use the 1,200 patients only for the EFS calculation. Okay.
So they're not going to share the PCR data.
Well, it doesn't make absolutely any sense not to do that, but that the statistics of the trial essentially talk about the primary endpoint being on the first 600 patients. They may not necessarily risk the fact that they may have a different result when they have 1,200 patients. So that was essentially.
That is very interesting. I just assumed they would share it, even though they don't need it for power, but that's interesting.
Definitely. So that would be an important information not to be lost. The other issue is that if you look at the forest plot, and this was a stratification factor, the regimen on the carboplatin seemed to be significantly different. I'm not sure if you addressed this in your presentation.
Yeah.
So do you use carboplatin in your regimen in the neoadjuvant setting? And if you do, what schedule do you prefer?
Well, truthfully, I don't really give much carboplatin in the neoadjuvant setting. You know, we have data from CLGB 40603 and from GEPAR-6 and while both trials suggest adding the platinum improved PCR, obviously they had differing outcomes in terms of outcome with DFS and not powered to really look at that, where GEPAR-6 suggests there is DFS benefit and CLGB does not. You know, I think to be definitive, to know if platinum is adding, we really need the data from the NRG study, which I think should be completing enrollment soon, of adding platinum to ACT chemo. And so without that, I have not standardly added platinum. You know, I think there's certainly patients who I start off giving AC and I feel like they didn't get a great, they're not heading towards having much reduction. So maybe I add on the platinum to their taxane in those unusual situations. But outside of that, I'm not standardly giving platinum. When I do give it the every 3-week way as was given in the CLGB study. But, you know, as you note in the keynote trial, it was choice of using the weekly regimen versus every 3-week treatment. And so, you know, personally, I think the weekly is much easier. As we learned in 40603 that there were patients who had to discontinue taxane early on 40603 in the carboplatin arm, and those patients actually did worse if they had to stop their taxane early in that arm. And so it does always worry me that I'm potentially compromising their outcomes if I'm causing, you know, the carbotoxicity, not getting them through their taxane. So we have no idea, though, if the carbo is even needed in 522, since everyone got it. And, you know, I think I am worried that once 522 comes to be a standard, you know, how we're going to get people through all that therapy, because it is tough to give ACT carbo, but then to give ACT carbo Taxol Pembro is tough.
I guess the comment also goes to the fact that added to all these difficulties on carboplatin, yes or no, the issue of the schedule has not necessarily been addressed, and this being a stratification factor, if you look at the forest plot, it looks that the weekly regimen was significantly better. With a significant difference in terms of PCR. So I was just wondering whether that is exploratory, of course, but
definitely interesting though.
It's an interesting concept that with all this issue of dose dense therapy being better and all these issues, even though the differences may be small, is something that we need to consider.
Yeah, and I wonder if it also lets them get through their taxane better, you know, keeping them on their weekly carbo.
It may be easier and maybe better even. So it's so that's the point. Thank you. Thank you very much.
So Sara, just going a little bit further on this question. So have you been using like neolastin or other stimulators during the neoadjuvant phase? Is there any data about the safety and efficacy if you combine GCSF with immunotherapy?
So with giving dose-dense AC, I certainly do give the Neulasta with every 2-week anthracycline therapy. And there is, you know, from the pilot studies, they did allow growth factor support with AC, and certainly even during 522, people were allowed to get growth factor support. You know, I think it, as you've actually shown very nicely, when people getting the dose-dense taxane portion of therapy outside of immunotherapy, you know, we often can omit the Neulasta in that phase for patients who haven't had prior neutropenia and who are younger. But, you know, I think it would become more complicated because in the 522 regimen, they're getting weekly taxane and either weekly or every 3-week platinum. So usually then we're just using, you know, like Neupogen, so GCSF instead of Neulasta if we need to.
Yeah,
I have a question for Romualdo. Is this the library in your house?
No, this is from my Hogwarts.
Where are you?
Hogwarts. So Barroso, I have to say that when I was planning to come back to Brazil, everyone at Dana-Farber asked me if I would work with you. You are the most known Brazilian in breast oncology for sure.
They know very little people in Brazil. That's why.
And I used to say no, unfortunately, but I'll try to be connected with him. I know. We have few other questions. So Sara, Luisa has a question about fertility preservation. So what do we know about fertility, especially for young women that will receive immunotherapy in the neoadjuvant setting?
So unfortunately, we don't really know very much at all. So I think that is a challenge that we don't know what the impact of immunotherapy on young women is in terms of impact on ability to have future pregnancies, as these data are also early and that hasn't been studied. And so I do think it is important to have a discussion with patients, particularly young patients, you know, about impact on ability to have future pregnancies. And I also worry about all these long-lasting toxicities that we're leaving young women with and how that could have an impact during pregnancies, right? You know, also if they end up with so many endocrinopathies, you know, thyroid, adrenal, diabetes, et cetera. Obviously those can cause high-risk pregnancies as well. So, you know, I do think it's an important discussion, but one that I certainly don't have an answer to.
Sara, I have one more question. Do you think like immune markers or immune signatures will help us to select the patients who will benefit from immune checkpoint inhibitors in the neoadjuvant setting?
No, I hope something does. You know, there are all these suggestions from some of the early work, like the even that AACR presentation, where there's a very interesting immune signatures and, you know, different ratios that do seem to predict benefit, at least in that, you know, PARP-based trial. So, you know, I don't know. I hope we find something, but to date, as you know, there's nothing that we have that's proven benefit. Even PD-L1, at least with 522, didn't even seem to matter in terms of, at least for PCR. So I don't know, but you know, clearly not everybody needs immunotherapy when PCR rates from ACT in general are around 50% anyway. So, you know, a lot of these patients do well, and we need to be able to figure out which patients really do need the immunotherapy. And I don't know who they are at this point.
Although not FDA approved, have you used pembrolizumab or any other immune checkpoint inhibitors in clinical practice outside a clinical trial for a given patient of your daily practice?
In the early disease setting? No, not outside of a clinical trial. So I do know there are some people who are starting to do it after seeing 522 reported, but I have not, because, you know, well, I think it is highly likely to be positive in terms of event-free survival given the trend we've seen at the interim. I think I just want to see that mature, because I am concerned about exposing people to the toxicity risk without actually having the mature data.
I think Dr. Sergio Simon has a question. We want to ask Dr. Sergio?
Hi, I did have a question, but I think it was answered. Is there any special feature, Dr. Tolaney, in a triple negative neoadjuvant setting that would make you go for immunotherapy, like lymphocyte infiltration or very young age or very high PD-L1 score? That will make us, despite the lack of approval for this patient, I think it's going to be a good indication.
I mean, from what we've seen in the preoperative setting, at least the degree of PD-L1 positivity did not seem to impact at least PCR rates. Again, we do not have those data for event-free survival. So, you know, at this point, no, we don't have any data to say that high TILs, high PD-L1, you know, some fancy immune signature or something is going to help us predict which patient's going to have larger benefit. So I don't know how else to choose excepting to potentially use anatomic risk as a marker for people where the risk-benefit ratio may make more sense.
So my impression, Sarah, is that these markers, especially the anatomic staging, will be an opportunity for de-escalating chemotherapy. So we know that anthracyclines have been the ugly duckling for everyone, but it seems so better for combining with immunotherapy that maybe we could avoid carboplatin and taxane instead. What do you think in a schema like AC plus P for early stage? Like,
yeah, no, I think certainly I've wondered if ACT Pembro would be similar to ACT Carbo Pembro in terms of event-free survival, because we don't really know that Carbo's adding to event-free survival at this point. But, you know, there is data, at least from Tonic, that platinum is also very synergistic with the IO. It didn't bear out with Neotrip, but maybe you need both. You know, I think there are now novel drugs that are getting developed, such as like sacituzumab govitecan. So could you imagine taking a new ADC, which has robust activity in triple negative disease, And there's some rationale to think that ADCs may be particularly synergistic with IO. Could using something like that get us out of an anthracycline, with IO? So I'm hoping there will be novel strategies to think about trying to change the chemo backbone in that preoperative space.
That's great.
Okay. Any more questions? I don't know. Sarah, I have only one issue. I was wondering why all studies started with taxanes and immunotherapy instead of starting up front with anthracyclines.
Yeah, no, it's a good question as to the order. I don't know that it matters, but, and I don't actually know truthfully why they selected it in that particular way for these trials. But, I think prior to these studies getting developed, the majority of the data came with taxane IO synergy. And I think the idea certainly is you do want to make sure you get that in first. Some people do develop issues, cardiac toxicity, other complications from anthracycline that doesn't allow them to complete their chemotherapy. And so I think at least when you get the taxane IO in, you feel like, that at least from this strategic standpoint was to get synergy with that combination. But, I don't know that it matters.
Yeah, because sometimes I think it may cause some confusions, like I will show in the first clinical case that we have. I think we can move to the cases. Romualdo, please. And then I will
one more question.
Sorry, Deborah, please go on.
Sarah,
I will share my screen, but Deborah, feel free.
Okay. Do you think it would be better if we give like neoadjuvant chemotherapy as a standard with anthracyclines and taxanes and maybe platins, and then select the patient to immune checkpoint inhibitor if the patient has residual disease, like the S1418? Do you think it would be a more rational strategy?
My worry is that the benefit of immunotherapy may be in when the tumor is present and may be greater when it's given concurrently with the chemo. And so I am worried that the SWOG trial is taking patients who failed to respond to chemo, right? So those are people who probably have low TILs, right? Because we know that TILs predicts for higher PCR to chemo. Yeah. So maybe we're actually selecting the people who aren't going to benefit from immunotherapy by taking that approach, which is, and it's also not given concurrently with chemotherapy where we know activity is also greater. So I do worry about that space with IO monotherapy.
Okay. I think Romualdo wants to do the save the date earlier.
No, actually, this was a problem.
Okay.
It was a problem between the computer and the chair.
All right. So let's start with the first clinical case, please. This is a 51-year-old female patient postmenopausal with a family history of cancer, pancreatic, gastric, and prostatic. No comorbidities. Next, please. She underwent breast conservative surgery for invasive ductal carcinoma, 3 centimeters, and no lymph nodes. So PT2, P and 0 and 0. It was a triple negative tumor with a Ki67, 80%, a high Ki67. So she was randomized to the protocol in PASSION 030, and she was randomized to atezolizumab with weekly paclitaxel and dose-dense AC. Next, please. The basal Esse and ALT was normal, 13 and 10. And as she started the first week of paclitaxel with atezolizumab, she was okay with the hepatic function. After week 2, okay. And after the 3rd week of the protocol, then S and ALT started to rise. So we can see that she had a AST 40 and ALT 87 after the 3rd week. Then she went for the 4th week, and the liver function test was like very similar to the week before. And in the 5th week, then it started to rise again. In the 6th week, she was like more than 10 times the normal. So then at that point, we had to make a decision if she was going to continue on the protocol or move on to dose dense AC. So I would just like to stop here and discuss this, because I asked you about the sequence, because I think that paclitaxel is a drug that is associated with hepatic toxicity sometimes. So is it a good way to start immunotherapy in the adjuvant setting with a hepatotoxic drug instead of starting with AC and then move forward to paclitaxel?
I mean, I think it's a good question. I think the challenge is this probably would have happened regardless of the order that you gave it. And so did this patient end up getting a liver biopsy to see if it was immune-related hepatic tox or not?
Well, this patient, she decided to be withdrawn from the protocol because she didn't want to go to liver biopsy. So the protocol, we had to do this, but she denied. So unfortunately,
did she get empiric steroids?
Yes, yes.
And things improved?
Next slide, please.
Oh.
Yes, she improved very well. She could move forward to AC, dose dense AC, and now she has normal liver function.
Okay, so the steroids, so it probably was immune-related tox if it got better with steroids. She didn't complete the taxane therapy? No.
No.
So she had only gotten 6 or 7 weeks of taxane?
Yes, 6 weeks of taxane and 3 doses of atezolizumab. But this patient, she had no like psychological to try. She was really stressed, yeah, so she couldn't move forward inside the protocol.
I see.
Yeah.
Yeah, no, that is unfortunate because in a sense it compromised her ability to even get the standard therapy, not completing all her taxane.
And what I would like to discuss, please, Romualdo, next one, is exactly that. Next slide, please. For discussion, how can we put immunotherapy in the adjuvant setting, putting the balance, toxicity, and benefit for this patient? And I'd like to open this for discussion.
Yeah.
So Debora and Jorge and Sara, so even if Keynote 522 is approved, and we will have the opportunity to use the whole regimen for T2 and 0 patients. So how would you balance this? So this patient had a 3-centimeter tumor, node negative, and she didn't receive the best regimen because she had the toxicity. So how do you think you will offer the treatment for them?
Well, I mean, I think hindsight is always easier. You know, now we know wasn't such a good idea to give her the immunotherapy, but in truth, you know, we also saw that the difference in PCR was, I think, only 5 or 6% in the node negative population in 522. And so the difference is small in PCR relative to node positive patients. And so I think generally T2 and 0s potentially, unless they had a really large tumor, could omit immunotherapy. I think it's a node positive population or really large tumors where I think we need to think about it.
Yeah, I just want to make a comment is that when you look at the numbers, for example, here we're talking about atezolizumab. If you look at the near trip, increased AST, ALT greater grade 3 or 5 was only 0.7% of the cases. So sometimes because of the unknown, since we don't have a lot of experience with IO, we see not so very common toxicities on a case discussion, and we might have the wrong impression that this is the normal. Where actually the normal, when you look at chemo, IO or IO itself, it's not the typical toxicities we see. But as Sara noticed, you can have lifelong toxicities. Those are the ones that we get worried about, like thyroid, like adrenal insufficiencies, you can get liver toxicity only with the taxane itself. This case is very clear that it was immune related because the corticosteroid reverted. But it's not what you see normally. I'm not sure if Sara agrees with me. And I think that we do need to better tailor treatment by the patients. I totally agree with you guys, T2 and 0, maybe it's not the case of immune therapy, but it's also the case for carboplatin in those cases, in my impression, in my practice. So maybe we're giving too much as chemo itself. And the thing about immune therapy, Romualdo, in situations like that, that if you do have an EFS benefit through all the patients, T2 and 0 and on, this question is going to be even harder to answer. And we might be even seeing in the practice some clinicians de-escalating the chemo and give you the immune therapy because of the EFS event. That's my opinion, right? So I don't know if Sara agrees, if Debora agrees. I don't think liver toxicity is like the higher end of the toxicities we see with immune therapy in this patient population.
Yeah, I mean, I think it's true that grade 3-4 hepatic tox and, you know, added tox relative to taxane is small, particularly with atezo. You know, we saw that both in Impassion 130 and from 522. So while a known toxicity, not super common to get immune-related hepatitis. But, you know, as you note, it's hard to make these decisions because they're rare and you know, it's hard to predict which patients are going to develop these side effects. So, you know, I think just the question I think is a fair one is really where does the risk benefit ratio kind of change to the point where we feel comfortable putting patients at risk for these side effects. And you know, I don't know that there's a perfect answer, but I think definitely node positive is probably a good cutoff to think about.
Debora, do you have any comments?
I have to change my computer to my phone because my battery is dying.
Okay, so let's move. So just to make sure that we will discuss like most interesting case, I will pass to case 4, and if we have time, we can move back to the other case. So switching a little bit the gears, we'll take advantage of Sara's expertise in HER2 disease. So we prepare some HER2 positive tumor case for discussions. So it's a 51-year-old male postmenopause with no comorbidities and no family history of cancer. So in her oncological history, she had a palpable nodule in the right breast measuring 5.5 centimeters and a palpable lymph node bulk in the right axilla. She had breast MRI with the disease showing up in the breast and in the axilla, and she had a HER2 positive, 3+ ER/PR negative, and a PET CT was performed, and she had a lymph node suspicious at the third level. So, but she didn't have any evidence of distant disease. So she had a T3N3 clinical stage in a 3C. So what would you recommend as a neoadjuvant treatment here? Nowadays, of course.
And sorry, her lymph node was biopsied as well?
No, I don't think so. I don't think she had a confirmation, but she had a lot of lymph node disease. So,
so it sounds like she has, you know, about a 4-centimeter cancer with likely lymph node involvement, hormone receptor negative, HER2 positive. So generally, I would give preoperative chemotherapy with anti-HER2 therapy, and you know, I think the standard regimen would be TCHP to give preoperatively, and would be very reasonable to do. I will say during COVID-19, we have been concerned about utilizing TCHP given high rates of febrile neutropenia. And obviously we do give it with growth factor, but nonetheless, one alternative to potentially consider would be TDM1 with or without pertuzumab. And we have data from Christine that suggests that while PCR is higher with TCHP relative to TDM1 pertuzumab in those patients without tumor heterogeneity who went on to surgery, then when we looked at invasive disease-free survival, outcomes were fairly comparable between the two arms. So in a HER2 3+ patient who likely doesn't have as much heterogeneity, it may be a reasonable alternative, although, you know, off-label therapy, so we'd have to see if it was paid for.
So anyone would add anthracyclines instead of TCHP, ACTHP?
I was always a fan of anthracyclines since I did my fellowship at MD Anderson. So like Dr. Buzaid say, I'm the queen of anthracyclines, but nowadays I think with the Catherine results, I think I'm okay with giving like TCHP. I think I'm abandoning anthracyclines in the neoadjuvant setting for HER2 positive breast cancer, given the data on the Catherine, and we know that it's an important regimen. The PCR rates are comparable between a non-anthracycline and anthracycline regimen. And we will have the Train 2 update at ASCO. I think it will be an oral presentation demonstrating the long-term results from the event-free survival from the patients who receive and who did not receive anthracyclines, and they are exactly the same. So I'm fine with giving only TCHPU nowadays.
Sara, can I ask a question for you? I honestly don't understand why carboplatin added to a taxane, since we even have negative results in a metastatic scenario, the BCRG07. I always ask myself, based on adjuvant results, the SAFEHER trial with TC, but the C being cyclophosphamide, if we could actually change the carbo to a cyclophosphamide, even though we don't have that arm in the formally done neoadjuvant trial. But considering the toxicity added to carboplatin to docetaxel as compared to cyclophosphamide, do you think this would be a total crazy schedule to offer a patient if you want to get rid of the anthracycline and the carbotoxicity?
So we do, as you note, there is data from the Steve Jones publication of Taxotere, Cytoxan, Herceptin in low-risk patients. So they did have some stage 1 and 2 patients in that trial. And it was 4 cycles of TCH. And the outcomes were outstanding from that experience. And I think it's a very good point. And I will say our group has asked the same question as, you know, what is the role of carboplatin here? It's very unusual to be giving platinum, and why did that come to be? You know, as you note, there's negative data from the metastatic setting suggesting that adding platinum to the taxane Herceptin did not add. But, you know, if you put data from Neosphere next to data from Trifina, you know, obviously PCR rates are very robust with TCH relative to TCHP relative to THP. You know, PCR rate is much higher. So, you know, I think I agree that we don't have a nice randomized trial comparing TCHP to THP. I think TCHP probably would win, given what we've seen just with cross-trial comparisons. And so then your question is can we just change the C from carbo to Cytoxan? Because that seems a little more logical in breast cancer. And, you know, again, we just don't have data. We only have the Steve Jones study that I think is a very nice study, but really for a lower risk population. So I've not done that substitution. I've used the TCH regimen in certain circumstances, particularly in someone who's sort of borderline HER2 that looks almost triple negative, but sort of borderline HER2 positive. I've sort of felt like, well, I'm hedging. I can cover them with TC and then TCH in case that HER2 is real. But outside of those weird situations, I don't usually use the taxane Cytoxan backbone.
Great. So I have to say that I'm a little bit surprised that you would not add anthracycline, but it's okay.
I tend to agree with Deborah that I used to always say anthracycline to everything, but then after Catherine came out, I sort of realized that, well, we can actually, adapt based on patients' preoperative experience and improve long-term outcomes. And so I sort of worry that I'm putting people at risk for anthracycline toxicity that may not be necessary anymore.
Just one word. Usually we start with anthracyclines because sometimes we don't have the HER2 status when we start chemotherapy in Brazil. So anthracycline is very good for that.
I see.
Yes, because in Brazil sometimes we get like 1 month and 2 months to get the HER2 status.
And if it's 2+, it's even worse because then we have to wait for the fish test. So then anthracycline is really great.
It's very practical.
Yeah.
Great, but the patient was onto neoadjuvant chemotherapy with docetaxel, trastuzumab, pertuzumab, followed by Esse, plus trastuzumab and pertuzumab. She had mastectomy, she had a residual disease, radiotherapy, but right now, I don't think we have questions about the best regimen for residual disease, but early in 2019, TDM1 was not approved. So I will skip this part of the case just for addressing the most important questions, I think. So she had a disease recurrence. She was started on TDM1. After 6 cycles, she progressed. So my questions will be focused on this progression. So she had the recurrence just in the end of the adjuvant HP, and she was started on TDM1. So 4 or 5 months later, she had a progression. So right now, after all these new approvals, if you have a patient that you can choose between these schemas, so what would you prefer?
So, I mean, I think really the choices are probably the HER2 CLION regimen with capecitabine, tucatinib, and trastuzumab, or using trastuzumab deruxtecan in this sort of like a third-line population, given that she recurred on HP and then got TDM1. So we know that the HER2 CLION regimen was associated with, a survival benefit relative to capecitabine, trastuzumab, but while the data for trastuzumab deruxtecan is only from a single-arm phase 2 study, the 16-month PFS is really an unprecedented progression-free survival that we do not usually see. The HER2 CLION PFS is in the 7-month range, and with trastuzumab deruxtecan, it's in the 16-month range. And so while, again, we don't yet have randomized data from the phase 3 trials with trastuzumab deruxtecan, it would be my preference in this patient. It's not a patient who has brain metastases, where I would potentially prefer the HER2 CLION regimen in a patient like that, but outside of that setting, I probably would do trastuzumab deruxtecan next, and then subsequently could do the HER2 CLION regimen.
Any comments, Deborah? Jorge? Okay, so I think the first question you already addressed. So would you prefer tucatinib for brain mets, is what I understood?
Yeah,
Okay.
I mean, I think the truth is, if it were normally with brain mets, we would radiate that patient.
Yes.
And so we would treat them as if they have stable brain mets. And, truthfully, if you look at the subgroup analysis from trastuzumab deruxtecan, there were 24 patients with a history of treated brain mets, but their PFS was 18 months. So I'm not sure that there's a need to preferentially pick the HER2 CLION regimen in someone with treated stable brain mets. I think you have to go with HER2 CLION if someone has progressive brain mets or untreated brain mets where you need systemic therapy, because we know obviously that combination has CNS penetration, has activity in the CNS, and there was even OS benefit in that subgroup. So I guess I'd qualify brain mets as either treated or untreated to help differentiate what I would pick.
Okay.
I have a question for Sara. Recently, FDA also approved neratinib for the treatment of metastatic HER2-positive breast cancer. Do you think neratinib has a role now that we have like tucatinib and trastuzumab deruxtecan?
I mean, it's hard because obviously the NALA study with capecitabine neratinib did not have an overall survival benefit, at least to date. And so it's, and obviously toxicity is much greater with neratinib-based therapy compared to tucatinib. And so it's, if you were choosing between cape neratinib and cape tucatinib trastuzumab, I would pick tucatinib. I think the question is then, well, what's the role for neratinib at all in the future? And you know, I think right now we don't know if neratinib could have activity post-tucatinib. You know, it is a different TKI. It's an irreversible TKI that is a pan-HER inhibitor, whereas tucatinib is HER2 selective and you know, is reversible. So I do wonder, could there be activity of neratinib post-tucatinib, but we have no data. So, you know, right now, I think tucatinib is the preference, but we need more work to know if there would be a role for neratinib in the future.
That's great. So now a tough question. So how would you put in context Monarch HER with deruxtecan and tucatinib in a ER-positive patient? So let's pretend that the patient had a ER-positive disease.
Well, you know, I think for ER-positive, HER2-positive disease, in my mind, at some point in time, one should give a hormone receptor positive, HER2 positive patient treatment with endocrine therapy and dual anti-HER2 therapy. That should be considered at some point. Normally, when I introduce that is in someone who, this is a little different in this case, but if someone got first-line THP, I usually drop the taxane and I put them on endocrine therapy, HP maintenance. And that's sort of how I make sure I get an endocrine therapy along the way. But in a patient like this who's, let's say, not really had much endocrine therapy, you know, the question is there a role for CDK4/6 inhibition and endocrine therapy and anti-HER2 therapy? And, you know, the challenge is that Monarch HER was a randomized phase 2 trial. And I think many people would argue wasn't conclusive because there was no control arm with endocrine therapy and trastuzumab. So the trial randomized people to get fulvestrant, abema, trastuzumab, or to get abema, trastuzumab, or chemo trastuzumab, but there was no control for fulvestrant with trastuzumab. And so while the triplet beat chemo trastuzumab, I think it clearly shows that CDK4/6 inhibitors with endocrine therapy and trastuzumab likely should have a role in HER2 positive disease. We can't prove that it was better than endocrine therapy and trastuzumab. And so, you know, I think, as you guys all know, there are ongoing trials further evaluating CDK4/6. Patina is looking at adding palbo to that maintenance phase with HP and endocrine therapy. There's the Patricia trial, which is also comparing endocrine therapy with CDK and trastuzumab to physician's choice treatment. So we'll get more work on it. I think at some point it may be a nice thing to offer the patient, but right now, given the plethora of agents that we have and the very robust data for trastuzumab deruxtecan, I think using the approved regimens would be my preference, and it would position the CDK4/6 a little later.
Great. Is there any other question? Great. So I'd like to thank Sara, Jorge, and Debora for joining us today. I think everyone agreed that it was amazing. And I'd like to invite everyone for our highlights of ASCO 2020. So we'll do in 2 days. We'll have this in 2 days, and we already have the speakers and the finalists. So it'll be June 15 and June 22. So thank you so much, Sara. Thank you.
Thank you so much for having me. It was really nice. And, you know, it's just a pleasure. Certainly, I feel very attached to Romualdo, having been with us for so many years. So it's really nice to be able to see him in action in Brazil now.
Thank you, Sarah.
Thank you, Sarah. Thank you, everyone. It was a pleasure.
Thank you. It was a pleasure.
E obrigada pelos que estão conectados até agora, nesse horário difícil do Brasil. E espero vocês nas próximas reuniões também. Thank you, guys.
Bye-bye.
Bye, everyone.
Bye.
Ciao, ciao.
Ciao.